Hello, we're glad you've joined us for this live webinar, Laboratory Medicine, What Should We Be Measuring? I am Judy O'Rourke of LabRoots, and I'll be your moderator for this session. Today's educational web seminar is presented by LabRoots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. Let's get started. You can pose questions to the speaker during the presentation while they're fresh in your mind. To do so, simply type them in the Q&A box, which will open when you click the green Q&A button at the lower left of the presentation window. Questions will be answered after the presentation. To enlarge the slide window, click on the screen icon in the lower right-hand corner of the slide window. If you experience technical problems seeing or hearing the presentation, just click on the support button found at the top right of the presentation window, or report your problem by clicking on the green Q&A button at lower left. I now present today's speaker, Brian R. Jackson, MD. Dr. Jackson is Vice President and Chief Medical Informatics Officer for ARUP Laboratories in Salt Lake City, Utah. He is also Associate Professor of Pathology at the University of Utah. Dr. Jackson received his MD from the University of Utah and completed a clinical pathology residency at Dartmouth-Hitchcock Medical Center. Prior to joining ARUP and the Utah faculty, Dr. Jackson was a clinical pathologist and informaticist at Dartmouth-Hitchcock Medical Center, a product manager for a Belgium-based medical software firm, and a National Library of Medicine Informatics Fellow at the University of Utah. His research interests include economic analysis of diagnostic testing and physician utilization of laboratory tests. He is certified in clinical pathology by the American Board of Pathology. Dr. Jackson will now begin his presentation.
All right, thanks, Judy, for the introduction. I appreciate the opportunity to talk about a topic this morning that I think is going to be a really important one, namely laboratory medicine. What should we be measuring? Or to put it a different way, as we enter the accountable care era for value-based healthcare, value-based medicine, how do we best manage the clinical laboratory enterprise? And by manage, we're really talking a lot about what metrics are we going to use. What are we going to measure? My baseline assumption for this topic is that the role of the clinical laboratory is going to evolve, needs to evolve, from running tests to having a broader responsibility over diagnostic processes. I'd like to frame this a little bit historically, going back about 105 years to the Flexner Report. And this is a perspective I picked up from Brett James, any of you who know him, the quality guru of internet and healthcare. Abraham Flexner was an educator who in the early 1900s was asked to do a comprehensive report of American medical education. And the reason for this was that American medical education was a real mess. Most doctors back then got their degrees from diploma mills. There was widely varying quality of medical schools and medical science and medical care. And the Flexner Report established that U.S. medical care and U.S. medical training needed to be science-based. So this was a really, really good thing. And it positioned us for where we are today, where healthcare is a very science-based profession, very science-based industry. But there was one downside, and that is all the emphasis on science, the management side of healthcare became sort of culturally separated from the science, to where we've created a whole separate class of healthcare administrators with different training tracks and different professional spheres from the practitioners of healthcare. And that's a little bit unfortunate. And I think it's important that those of us in the healthcare practitioner space go back to management science and look for opportunities to incorporate that into better running of our laboratories. I'm going to use sort of a factory analogy. I realize that this is extremely limited, that in many ways healthcare is not like a factory, and I could go through those reasons, and it's a long list, but there's some ways in which using factory analogy just sort of simplifies the paradigm of thinking about management. In the healthcare space, the key variable that we're looking to manage here in diagnostics is the doctors. Historically, laboratories haven't really thought about managing doctors, but really that's what we need to do in healthcare, is manage what doctors do. That doesn't mean we 100% control them. Doesn't mean that we take away all of their autonomy and all their intelligent decision making, but it means that we think about them rationally in a management sense. Managing doctors, just like managing factories, is not about a particular tool or even just a family of tools. It's not about a particular technique or particular technology. It's really a system. And the simplest way to represent the system to a biology-trained audience would be in the form of a feedback loop. In a management system, you need some sort of a governance structure. Someone needs to be in charge, or some entity needs to be in charge. But in order to govern, you need a combination of data and controls all put together within feedback loops. This is not an unfamiliar concept to those of us who have had a lot of education in cellular biology, for example. But management really does work the same way. So you manage what you measure. You set up metrics on how your lab's performing, and you set up controls to essentially you want to move towards self-correction, but controls that correct based on whether your lab is operating the way you want it to or not. If I were managing a factory, these are the types of metrics that I would want. And there are a lot of them. There's not one single measure of whether your factory is performing well or not. These metrics can be grouped into categories, however, for convenience. Costs are obvious on the right-hand column. Costs are obviously an important part of managing any business enterprise. And those costs need to be measured at a very granular level, so that you know the cost of every specific item that you order or every employee that you hire. But you also need to be able to roll those costs up to an executive level to know what the total aggregate amount is that you're spending. Likewise, if you're running a factory, the outcome of interest is usually revenue, and so you need to measure that at a granular level, but also rolled up to an executive level. But cost and revenue, it's not just about the money. Even in a factory, even if your outcome is all about the money, running the factory is not all about the money, because if you don't have quality, you're not going to get that money. And so you need to be able to measure those variables which link cost to revenue, the variables which cause your products to be sellable and desirable and so forth. So you need to identify the quality measurements that connect those two. And again, measure them at a frontline granular level, but also rolled up to an aggregate level to know if your overall quality is where you want it to be and how far away it is. So sort of think of that as sort of a model of measurement in a business setting. So how could we translate this into a healthcare setting, particularly around diagnostics? As I said before, healthcare is different than a factory. So we're going to have to adjust this a bit. The cost category is sort of the easiest one to translate, because in a laboratory we obviously have costs. We have supply costs, we have personnel costs, and laboratory managers today generally do a good job, are familiar with the problems of measuring costs. I would argue that there are some changes that need to be made here, though, in terms of thinking about costs from a healthcare system perspective rather than just a purely laboratory perspective. And I'll explain that in a minute. If you go to the left-hand side of the screen, let me pull up my whiteboard here. So go to the left-hand side of the screen, quality measurements are obviously really important in a healthcare setting. They're going to be different specific measures from a factory, but the concept of measuring quality is understood. The middle category I've changed, and that's the outcome category. In a factory setting, in most business settings, if you're running a factory, your outcome of interest is dollars. But in healthcare, it really isn't. We pay attention to the dollars coming in really because we need to cover our costs. But the outcome of interest in healthcare is really patient benefit. If we want to know, are we succeeding as a clinical enterprise? If we just say, yeah, we were profitable last year, that's not very satisfying. But if we say that we met the needs of the clinical enterprise to take care of patients, that's really the goal that we care about. Now, if you look at all of these categories, costs, patient benefit, quality, and granular rolled up to the executive level, where do we have good metrics today? I would argue that we have, in most clinical laboratory settings, we have pretty good metrics in the rolled up costs and the granular level quality. But other than those categories, I think we've got a lot of work to do. And that's what I'm going to be talking about today. So the work to do is in everything else. The rolled up quality measurements, the granular level costs, but not from a lab perspective, but really from a healthcare perspective. And then all the patient benefit measurement is really challenging. But it's something that we can get started on. Okay, so let me start with costs. Again, when you're speaking in sort of business language, this is one of the areas that is the easiest to relate to. Most laboratories today already have a really good handle on sort of the traditional cost items that from a laboratory perspective. So you know what you're paying your employees and labor, you know how much reagents cost, instruments. Hopefully you'll have a sense of the cost of your facilities and in your settings. But if we're going to truly manage costs in a way that is integrated into value-based healthcare, we're going to have to rethink this about a bit. Well, we don't throw away what we already have, but we have to add to it. Importantly, we need to know our cost per test. Now, that may sound obvious, but as a laboratory, most lab managers today think in terms of, you know, I spent this much on reagents, I spent this much on labor. But to really get down to cost per test is trickier than it sounds. You think, well, you take all your labor and reagents and divide it by the number of tests you run. The problem is that your techs are running multiple different tests on the same instrument. And they may be managing multiple instruments at once. So all of your instrument overhead, all of your labor needs to be allocated properly to the different orderable tests, and that's tricky to do. In some hospital settings, lab managers sort of cheat and use the hospital charge master or Medicare fee schedules as a surrogate for what tests cost. This becomes important, for example, if your doctors ask you, how much does this test cost? Sounds like an easy question. Do you have an answer for them? And if you just give them the Medicare allowable amount for that test, it's going to be really biased because Medicare fee schedules are really biased. And hospital charge masters are even more biased. So this is something that takes a bit of work. Once you've got cost per test down, then you can start thinking about cost per case. Well, this is even trickier because you need to start taking into account how many tests of different types get used for different types of clinical cases in your clinical enterprise. Has your laboratory ever done that before? I would say that in the vast majority of settings that has not been done. In order to do that, you have to have valid costs at the component level, but the overhead allocation really gets tricky. And the variation in clinical care is what gets really tricky. So a heart failure patient is not a heart failure patient. You know, one heart failure patient may be really stable and need an occasional BNP or an occasional who knows what. Let's just stick with BNP. Another heart failure patient may be really unstable, have a lot of doctor visits, and they may have a lot more lab tests. So figuring out your cost per case in terms of lab testing is really dependent on who those patients are, how sick they are, and the practices of the doctors in how sort of lab heavy they are in their clinical practice. There's a really good article about 4 years ago in the Harvard Business Review by Robert Kaplan and Michael Porter. Now, these are not physicians. These are business school types. They're actually quite famous strategy writers in the academic business world. But what Kaplan and Porter basically laid out was a cost accounting method that could be really useful in healthcare. And it really comes down to how do you estimate in a reasonably accurate, reliable fashion the cost per case of care. And once you've measured the cost per case so that you can know, our hospital spends this much on heart failure patients and the distribution looks like this. But importantly, the contribution of laboratory testing is this much, the proportion of physician professional charges, not professional charges, but professional costs is this much, the contribution of nursing is this much, and so forth. Then you can really start to manage the components and see where your outliers are, where your biggest waste is, etc. Most hospitals have not done this. Here at the University of Utah, we actually have done this. It's something we call value-driven outcomes, and you can, there's some New York Times articles which describe it sort of a high level, what we're working on here. It's a really interesting topic and really useful topic. Okay, if in your laboratory setting, if you want to make progress on measuring costs, there are easy things to do, there are hard things to do. I would say that the lowest hanging fruit here is to start tracking the cost of expensive test categories by ordering department and physician. So you know who's ordering your $5,000 tests in large volume, because those are the ones that really have the fastest potential to get your costs out of whack from a clinical perspective. A little less low-hanging fruit would be to cost out your entire test mix. Again, don't start with a charge master. Don't start with third-party fee schedules. It really needs to be done ground up. And then in the long run, it'll be really great if we can estimate our diagnostic testing costs per case for different types of diseases. But that does take a lot of work. Okay. Next category, if costs are the input, then patient benefit is the output. So how do we measure patient benefit, or how can we measure patient benefit? A lot of people look at national measurement systems, national quality measurement systems, and put a lot of expectation and hope in those kinds of systems. So, HEDIS, the CMS, ACO measures, things coming out of the National Quality Forum, etc. These are measurements that the payers are currently using to measure our quality. So, hey, why don't we use them as well and use these as a measurement of how well we're benefiting patients? There's several problems with these. The most obvious glaring problem is that nationally vetted quality measurement systems are essentially looking under the lamppost for quality. They're measuring things that are the easiest and most politically defensible to measure, but they're measuring a very, very tiny fraction of overall healthcare processes. So a full-service hospital will treat hundreds of different diseases, and every one of those diseases is going to have a wide range of a wide variation of patients that come in, and every one of those patients is going to receive a tremendously broad mix of services over the course of a clinic visit or a hospital stay. So literally, you can come up with hundreds of thousands of processes that all need to be managed. And yet HEDIS, which is the main health plan level quality measurement system in the US today has under 100 measures in it. You're not going to be able to representatively measure the quality of your of healthcare with 74 measures. You're just not going to do it. It's going to be really really skewed. And what makes it worse is that hospitals focus disproportionately on improving their scores on things like HEDIS, which means that that whatever your quality score is going to look a lot better than you're actually doing. But it gets worse because out of those HEDIS measures, only a small portion of those measures has a significant diagnostic component to it. And of the ones with a diagnostic component, only a small number have, or a small minority have a clinical laboratory element to it. So there are only 9 measures in HEDIS that have a significant clinical laboratory measure. And for example, hemoglobin A1C measurements in diabetes is one of the main ones. But we have hundreds of laboratory tests that are used in hundreds of different diseases and settings. So how will 9 measures tell whether we're doing a good job in meeting the needs of our patients? The answer is that it won't. You said the same thing about the ACL measures. I put choosing wisely up there, even though it's not really a quality measurement system. But these systems are not going to solve our need to measure our the patient benefit of our clinical laboratory. It's important to point out at this point that patient benefit per test is not primarily a function of it's not just a function of the test attributes. In other words, how accurate the test is. It's largely a function of how the test gets used. So the example I use here, and I've put a reference for a paper that I was part of, studying the cost effectiveness of Helicobacter pylori testing. And in that setting, in Helicobacter pylori, we've got a number of different lab tests available, and they vary in cost, they also vary in accuracy. And it turns out that the patient benefit of all of those tests, in at least some settings, is virtually the same. Because in a lot of US settings, doctors jump to endoscopy so quickly in their diagnostic algorithm that non-invasive testing really doesn't, the accuracy doesn't matter that much because in a lot of US settings, there's essentially redundancy of the testing by use of endoscopy and invasive testing methods that it overcomes the variation in the non-invasive tests. So again, the bottom line here is if you want to look at trying to measure patient benefit per test, you have to start by looking at how the doctors are actually using the test and not just think in terms of the test's own accuracy or reliability. If you want to go from patient benefit of a test to the total patient benefit of testing per case, really ideally what we're talking about is outcomes. So we'd love to know if a more accurate BNP test is going to make a difference in heart failure outcomes, or for a more accurate troponin test or a different cutoff for troponin, how that impacts the outcome of MI patients. The problem is that measuring those outcomes, in most cases, measuring the outcomes of different diagnostic decisions or different diagnostic tests, in most cases is not practical. Because there's so many variables in between the diagnostic test and the patient outcome. The therapeutic decision making really washes out in a study sense the measurable impacts of the diagnostic test. So measuring outcomes, it's what we'd love to be able to do, but it's not going to be practical in sort of a controlled way to try to measure our benefit that way. There are 2 other options though, and I call them the normative approach and the non-normative or descriptive approach. The normative approach would be to simply measure the use of our tests against some external benchmark, such as a guideline or expert opinion, or even just our own sort of attempt to summarize the clinical literature. essentially what we're talking about here is evidence-based medicine. And it's a very reasonable approach to use. There are some limitations here where I don't think it's going to solve all of our problems. And so I think we need to complement that with some non-normative approaches as well. So on the evidence-based medicine side, diagnostic testing guidelines are very useful where available. The main problem with them is we don't have enough of them. There are a lot of guidelines in the world, but they don't cover the majority of clinical scenarios that are out there in the real world. And they particularly don't cover the majority of diagnostic decisions and diagnostic procedures that are available in the world. One example of where we do have a good guideline is for cervical cancer screening. So there's a guideline that's been out for quite some time now. It's been revised over time for cervical cancer screening. This is the ASCCP guideline. And it's a very thoughtfully developed guideline in conjunction with laboratory and obstetric gynecology professional societies. So one thing we can think about doing is measuring the testing practices that we see in our community against that guideline to see are doctors following the guideline. I think this is a useful thing to do. So in our laboratory, we took a piece of that guideline, which is HPV testing and what kinds of HPV testing you'd expect to see if the doctors are following the guideline. One thing that you can look at is testing on patients under the age of 21. So the guideline says you never do cervical cancer screening under the age of 21. There are good clinical and biological reasons why it doesn't make sense to do that under 21. So in this histogram, I show the proportion of HPV tests received, the proportion of orders for HPV received in our national reference laboratory for patients under the age of 21, and I show this by year. So in 2003, 2004, 2005, the proportion was about 13%, which is bad. That means a lot of patients under 21 were getting tested that were being put at risk at harm. But then what you see is that starting in about 2006, this proportion started to taper off. What happened was in 2006, that's when the first version of this guideline was published, which for the first time made it really clear you should never be testing under the age of 21. And so what we see here is a response by the clinical community to that guideline. Now, it didn't happen immediately. That proportion didn't drop to zero immediately, but it did drop down over about the next 6 years. So it's a good news, bad news kind of a glass half full, half empty kind of a situation. But I'm just using it as really as an illustration of the kinds of things that we ought to be measuring if we want to be measuring whether we're doing a good job by our patients. Another portion of that same guideline has to do with repeat intervals. If you do cervical cancer screening using the modern algorithms as opposed to the decades-old annual pap smear sort of simplified algorithm, then one of the benefits for patients is they don't have to get tested every year. And again, in this slide, we show a change over time. The y-axis is the number of months following a negative HPV result that we see the next HPV test ordered. And in 2006, when that first guideline came out, the median interval was 12 months, and that interval has gone up over time. So we see people following the guideline even if it's not 100% and if it's not 100% immediate. Okay, so again, the problem with using guidelines as our sole means of measuring our patient impact is that we don't, unlike the cervical cancer screening example, for most diseases we don't have comprehensive guidelines that prescribe how to use all the different diagnostic tests we have on our menus. And so we need something to supplement that with. And my proposal is we supplement that with a lot of variation measures. By variation measures, we're just looking at differences in doctor practice. So measurement of clinical variation has been around for a few decades now. It really started in a big way at Dartmouth with the Health Services Research Group there. Some of the nice things about measuring variation is it's non-judgmental. So if you go to your clinical community and you say, you know what, I see a fourfold variation in the volume of BNP testing that's done in heart failure patients that's attributable to physician variation. I didn't phrase that very well. If I see a fourfold difference between the doctors who ordered the fewest number of BNPs on their heart failure patients versus the doctors who order the most BNPs on their heart failure patients. When you put that information out there, it doesn't imply that the laboratory doesn't need to be in a judging mode. The laboratory is just making that information transparent. But it creates an invitation for the clinical community to have some conversations around that. And you can do this for all of your testing. The Dartmouth Atlas website has a lot of variation measures on it, which are really fun to look at. But what I'm showing here is a measure of overall hospital care intensity, where you see the darker colored areas of the country tend to do a lot more health care per capita than the lighter colored areas of the country. The Dartmouth Atlas group does a lot with Medicare data, and so unfortunately they don't have a huge amount of diagnostic variation data that they've published, because it's, with claims data it's harder to manage to do the measurement on lab tests, because you're working with CPT codes, which are clunky. Here's on the next two slides. I'll show some internal numbers in our National Reference Lab, just to illustrate the concept. So there are a couple of tests out there which are sort of like super cholesterol tests. There's the NMR lipid profile and the VAP cholesterol test. Two different methodologies, but both of them basically correlate with the LDL particle number as opposed to LDL mass, and there's some evidence out there that may correlate slightly better with cardiac risk. The evidence is not clear in my mind that these tests are ready to overtake the inexpensive LDL measurement that we do in most of our hospitals today, but I'm just using this as an illustration of variation. So again, I said the two tests are reasonably comparable in terms of the information that you get. In this heat map of the United States, the darker states order a much higher volume of the NMR lipid profile than the light-colored states. If I go to the next slide, I did the same thing with this other test, and you see that it's a different set of states that show up dark. So California, I'm going to go back, California has high volume usage of both of these tests, and Montana has low volume usage of both of these tests. But if you focus on Nevada and Iowa, Nevada is very low for VAP cholesterol, and Iowa is very high. But Nevada is very high for NMR lipid profile, and Iowa is very low for that one. So reverse. So the bottom line is this pattern looks pretty random. Is there any chance that this pattern is being driven by differences in patients? No, because your cardiac risk is not going to be, or the things that you want to measure for cardiac risk are not going to vary according to these patterns. What you're seeing is physician practice variation, which is largely driven by sales and marketing activities by the companies that produce these tests. So there's an enormous amount of variation in physician practice is the bottom line. We can see it in the National Geographic basis here, but you can also see it in terms of local variation in your local physician communities, and it becomes a useful thing to measure. Here's another example, a very practical example of how variation measurement can lead to an improvement. A number of years ago, we identified an academic medical center who was a client of our laboratory, who represented about 1/3% of our national lab testing work overall, but represented 95% of a particular panel, which happened to be a whole blood drug abuse panel. It was about $70,000 a year. Sorry, I'll stay on this slide. It turned out that so the variation, the measurement of the variation that we did to identify this allowed, it brought attention to this issue, which had not been on the attention list of this hospital laboratory prior to that, and allowed them to look into it and discover that it was a process error on the part of some of the nursing units that were ordering the wrong test. And as a result, they were able to save a lot of money and provide better clinical care for their patients. But it was the variation analysis which allowed this to be discovered. Okay, so when you're measuring variation, just a couple thoughts. You need to have reasonably valid comparison groups, but when you're measuring for management purposes and clinical purposes, you don't have to hold yourself to a sort of a randomized controlled trial or case-controlled series in the research sense, because you're targeting sort of reasonable, plausible validity, but you don't necessarily have to hold yourself to publishable science levels of validity, as long as you're really transparent about what you've got. Benchmarking is useful at multiple levels. Measuring within a physician group is extremely useful, but if you can also benchmark against doctors across hospitals, across health systems, across geographic regions, then you add a lot of power to this. When you do variation benchmarking, make sure you're using raw volumes and not looking at, say, aggregate charges or aggregate costs, because the way that charges and costs in most hospital systems, because of what we talked about earlier, are usually really, really biased and not comparable across hospitals. Because most laboratory costing in hospitals is based on charge masters and or some sort of a modified, third-party fee schedules. It's going to really throw your, going to introduce a lot of bias into the system. So when you want to measure variation, just pull the volumes out of your lab information system, use the raw volumes of tests, and then look at the variation. Again, a low, medium, high complexity approach here. The lowest hanging fruit here would be to set up a system in your laboratory of systematically tracking variation in ordering patterns by department and by physician. And just doing those measurements, making them public, will actually have a big impact on your clinical community and sort of the controlling the conversation about utilization of lab tests. Comparing ordering patterns against clinical guidelines is a little bit harder. But again, we should be doing that, at least in cases such as cervical cancer screening, where we have good guidelines to work with. Measuring diagnostic outcomes is something that we can keep as sort of a pipe dream down the road. I don't think that one's going to really be feasible in the foreseeable future. Okay. So we covered costs, we covered patient benefit. I want to say just a few words about quality measurement in the clinical diagnostic laboratory setting. We do a good job in clinical laboratories of measuring quality at the test, at the instrument level. The clinical laboratories are really good at doing quality control and proficiency testing, and basically putting systems in place at the instrument level to make sure that that we understand the accuracy and the reproducibility of the tests that we perform. Those are not the only variables that are important to the patient and to the care of the patient. Turnaround time turns out to be a really, really important variable in a value-based care environment. And some laboratories have really good systems of measuring turnaround time across their spectrum of laboratory tests. But typically, in most settings, that's done mainly at the per test level. The opportunities that we have here are rolling these quality measurements up from the sort of the instrument level up to the patient, through the patient population level. So it's great that we can do turnaround time on a per test level. So we know, what does our turnaround time distribution look like for BNP, for example. But what's really needed to apply this in a value-based care setting is we need the turnaround time not from the test perspective, but from the patient perspective. So for a heart failure patient showing up in the emergency room who's decompensating, do they need a BNP? Well, that's maybe another question. But if they do need a BNP, or they certainly will need a troponin and a metabolic panel, what's the turnaround time in that setting? And separately, what's the turnaround time in so for an outpatient clinic visit for those same tests? So doing it from the patient perspective of the different patient populations is where the real power in turnaround time analysis comes in. And then finding some way to roll all of these quality measures up to the overall sort of health system level is going to be a little bit trickier. But that's sort of the long-term thing to keep in mind. If you wanted to look at expanding your quality measurements for your clinical laboratory, I would recommend starting with turnaround times for key diagnostic categories. So again, if you want to look at your troponin turnaround time, don't just look at it as what's the distribution of all of our troponin turnaround times, but rather split up into emergency department, critical care units, outpatient, because they're different. You're dealing with different patients and different clinical scenarios there. Where do we want to head with this kind of thing? Here at the University of Utah, our orthopedics department has come up with a system they call Perfect Care. And basically what they did is that the orthopedists sat down and started analyzing, for each type of clinical process that they have. Or let me rephrase that. They started with joint replacement. They said, okay, if we're going to replace a knee, what would be the perfect care approach to replacing a knee? If everything went very, very smoothly, we did all the processes in a high quality way and an efficient way, what would that look like? And so they split out so that to create metrics for the nursing processes, metrics for the physician processes, metrics for the patient education processes and the post joint replacement physical therapy, and put that all into sort of a comprehensive management system that they now compare themselves against. We need, now with joint replacement, lab tests don't play quite as big a role as they do for a lot of other disease management and care processes. But this is the sort of thing, if we really want to look at the quality of our lab, we need to look at the quality of our lab in the context of what the docs are trying to do with their patients. And so it can't be a lab alone quality measurement system. It really needs to be a clinical care quality measurement system that has lab measures mixed into it. And again, diagnostic outcomes are, what we'd love to do, but it's going to be hard to measure this. Okay, so again, just wrapping up and summarizing here. Today in healthcare, laboratories tend to have good measurements around the cost buckets from a testing perspective. So we know how much we spend on reagents a year in our lab. We know how much we spend on labor in our lab. But the opportunities there are to get down to cost per case. Again, this is the opportunity side. On the quality side, we've tended to, in the clinical laboratory, to have good measurements at the instrument level, but we need to figure out how to roll those up to the patient level, which means integrating into larger systems of measurement that need to be done at the clinic level and at the hospital level. And then in terms of how do our lab tests benefit the patient, which is really the most important category, this is also the category where we have the least robust measures available today. And we need to put the most effort into developing these. And we need to think in terms of benefit per case, where we use guidelines where available, but where not available, that we have systematic processes for measuring variation. And once we get a reasonable systems in place to measure, laboratory diagnostic benefit at the case level, then we can begin to think about rolling those things up to overall quality measures in the hospital, so that we could say, yes, our laboratory has gotten 50% better at producing good patient outcomes than we were 10 years ago. I mean, today we absolutely would have no basis for making a claim like that. But if we start by doing the benefit per case, at the per case level, we may be able to come up with at least some sense of whether we're going in the right direction at the overall population level. So, where this all heads over the long run, and really the importance of all of this, is going from a laboratory-centric perspective on laboratory medicine to a medicine-centric perspective on laboratory medicine. Because in the long run, what really counts in terms of what we really want to be measuring and thinking about measuring is the impact that happens at the medicine end of things. And what we do in the laboratory is really, really important, but it's important as a means to the end. And so that our eyes need to focus more on the medicine side of things over the long run, and not just on the laboratory side. So with that, that concludes my my presentation for today. And I am available for a few minutes if there are any questions.
Thank you, Dr. Jackson, for your presentation. A quick reminder for our audience on how to submit questions. Simply type them in the Q&A box found by clicking on the green Q&A button at the lower left of the presentation window. Dr. Jackson will answer as many questions as time permits. And the first question is, what do you see as the role of payers in this sort of system? Should they be a major player in measurement of clinical diagnostics?
Okay, so the role of payers, because I didn't really talk about payers in my presentation. Payers are interesting in that historically, payers have had a lot of data that wasn't necessarily available at the clinical enterprise level. So it's not a coincidence that one of the first sort of national level clinical quality measurement systems was HEDIS, which is a measurement of health plan data. The problem with the payer side is that payers are disconnected from the clinical enterprise. And so the data that payers have is is distorted by the measurement systems, and payers, even more importantly, don't have good management techniques to provide feedback loops into improving clinical care. Now, some of you may challenge that and say, well, what about something like pre-authorization? Because in our healthcare system, there's a lot of pre-authorization that goes on as an attempt to enforce and promote cost effectiveness. But any clinician will tell you pre-authorization is horrible from the clinical perspective because it's just incredibly inefficient. Payers are not at the front line of clinical care. They can't produce nuanced, patient-sensitive judgment calls in terms of resource utilization and so forth. So if we're going to really manage clinical care properly, we need to be doing it at the patient level, not at the 50,000-foot level of a payer. So honestly, my bottom line is I don't see a really important role of payers long-term in quality measurement, and certainly I don't see a role for payers in quality management. This is something that hospitals and clinics need to take responsibility for, and not relegate that to the payer side.
Have labs in general started using big data methods leveraged across a region or network, or are lab environments so different that the data would be too noisy?
Okay, interesting question. Big data is a really hot topic in the business world today. Yes, big data, all data is noisy. And data scientists that work with big data know that all data is noisy. But there are ways to normalize and standardize and clean data to produce useful results. So just for example, if we were to look at variation analysis for laboratory tests, if you were to use, and there are consultants out there that do this, so I'm not imagining this scenario. If you were to benchmark laboratories against each other in terms of total lab spend using charge master level data, and again, there are consultants who will go out and do this. That kind of thing is going to be incredibly noisy, and it's garbage in, garbage out. You're not going to get any useful results, and you'll get really misleading results. On the other hand, if you were to do benchmarking across clinical enterprises using raw order volume data, and if you made sure that your denominators were reliable and transparent, so if you had, say, total number of BNPs per heart failure patient per year, and measure that in Salt Lake City versus New York City, that kind of a comparison would have face validity. So yeah, I see a lot of opportunity for going much bigger on the data side, and I'm pretty optimistic there. If we're careful about it, there are ways to deal with the heterogeneity. It's not trivial, but there are ways to deal with it.
How would you evaluate the value of a new diagnostic test that currently is not being tested for?
Okay, that one is a really important question, and this deals with when tests come onto the market. This is a really important question. What's the value of that test? The problem is we really don't know at that point. An idealized scenario might be if new diagnostic tests went through massive clinical trials before coming onto the market. And that's what we do with new drugs, for example. You invent a totally new drug. In order to get through the FDA, you have to do massive, randomized clinical trials and get at least some sense of the this isn't FDA language, but basically the patient benefit for that new drug. That doesn't happen in the lab. And frankly, it's not ever going to happen in the lab because it's not practical. Massive clinical trials are really, really expensive. And it would add to the cost of laboratory testing. What we need to do is come up with better ways of measuring the value in the course of actual clinical practice. I think disease registries have some potential to do this. For example, if you look at the kind of work the Cystic Fibrosis Foundation has done over the decades in improving cystic fibrosis care, one aspect of cystic fibrosis care that has improved over time by being studied and systematically worked on is the diagnostic side. What do you culture in these CF kids? How do you culture them? How do you standardize those processes? These are improvements that were made with the support of the systematic data collection, which happens through the Cystic Fibrosis Foundation and related areas. So I think the goal is we need to set up systems to really to measure what's going on, first of all, in routine clinical care and the component, the laboratory component of that. And then we can go back and try to estimate the benefit side of it. It's not easy. And when new technologies come out, pretty much by definition, we don't know whether there's any real benefit to patients. Because when new tests come out, basically what we have is some sort of first principles argument about how it's better. We say, well, this new cholesterol test, is going to be more accurate at predicting cardiac risk because of X, Y, Z. But what we don't have at that level is an actual clinical trial that shows that the decision making by the doctors is changed in a significant enough level and direction to actually produce better outcomes. So it's a hard one. The bottom line is it's really hard to measure outcome. But the only practical way to do it in most cases is by measuring measuring what goes on in actual clinical care as opposed to expensive clinical trials, because the expensive clinical trials usually don't happen.
Is there a link between a laboratory measurement and a particular medicine?
In many cases, yes. So I think the question is getting to the there's sort of a new let me think about how to best put this in the context. I think from the laboratory side, I think we need to think much more in terms of how do our tests change clinical decision making. The link is a human link, and that's important to recognize. If we have a test that tells you that drug A is going to be better than drug B, it doesn't automatically mean that doctors are going to use drug A when the test is positive rather than drug B. It just means there's a potential to influence the choice of the drug. So it's a human link, and we need to be really sensitive to that. Oncologists, for example, tend to be much more sensitive or pay much more attention to lab tests that tell them that they can use a particular chemotherapy to treat their patient. And oncologists pay relatively less attention to lab tests that tell them that they don't need to use a particular chemotherapy. That may sound like a subtle difference, but it's actually really important from the patient perspective. we need to be, we need to not automatically think that all of our lab tests are being used, um, are being linked as tightly to therapeutic decisions as they potentially could be. I'm not sure if that's where the writer of the question was looking to go with that, but I think that is an important thing.
I would like to once again thank Dr. Jackson for his presentation. Do you have any final comments today, Dr. Jackson?
No, other than really appreciate the opportunity to talk about a topic that I think is going to be one of increasing importance in our healthcare world.
I would also like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand through May 12, 2016. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.